again and some hints. So if you have a low platelet with MPV increase, then there is a possibility that there are a lot of platelet who are regenerating into the circulation. So that gives the idea that it could be ITP, or at least the production of the platelet is good as compared to MPV low, where the production will be decreased. So the thrombocytosis, the causes can be as simple, they can be reactive, secondary to trauma, surgery, blood loss, iron deficiency. So blood loss and iron deficiency anemia. So many of you send me patients saying that patient's platelet have gone above 6 lakhs. Then iron deficiency anemia, there is a simultaneous anemia along with microcytosis happening. Then iron deficiency anemia causing reactive thrombocytosis is one of the most common cause, and the inflammatory infections are the uncommon. But there is something, a myeloproliferative disorder, that is cancerous condition where the platelet can be increased, and that is called essential thrombocythemia or essential thrombocytosis, which is a type of myeloproliferative disorder. There are diagnostic criteria and they can eventually progress to myeloid malignancy in future. And thrombocytopenia, the first very important step in any thrombocytopenia is to check it on the peripheral blood smear. The spurious or the pseudothrombocytopenia is where the counter machine, because of its principle, says that platelet is low, but when you actually look at the peripheral smear, it can either show you aggregates or they can show the large platelet. Once you count them manually, it turns out to be a normal platelet count. Then there could be causes like ITP, it could be medications induced like linezolid, or it could be viral infections, and some of the rarer causes are hemolytic uremic syndrome, leukemia, sepsis and hypersplenism. Just to complete the components of the blood, the plasma is a liquid component of the blood and which includes protein, lipids, dissolved salts and the glucose. Out of that, as a hematologist, something which is of interest is protein. So if you have certain conditions where the globulin part of the blood can get increased, and that can lead to a lot of proteinaceous background on the peripheral blood smear, and that typically happens in cases of multiple myeloma or Waldenstrom macroglobulinemia. So if you have patients with high globulin, that also interferes and it can be picked up on the peripheral blood smear as a rouleau formation. Coming to the red cell indices and some of the parameters, hematocrit is basically percent of volume of blood which is occupied by the red blood cell. So, and hemoglobin and RBC count. Basically these are simple definitions. All of three generally move in line with each other. There are certain conditions where certain portion changes, like hematocrit could be concentrated if you have a dehydration. So if you have a polycythemia vera, your hematocrit becomes a better indicator. If you want to have a look at the hemoglobin or anemia, the hemoglobin is a better parameter. And then comes the RBC count. RBC count can be generally low in line with the hemoglobin, but if you have an ineffective erythropoiesis, that you have a RBCs which are produced but they are not contributing to the hemoglobin formation, and that happens in ineffective erythropoiesis like thalassemia minor. So in that case, you have a RBC count which is remaining into the normal range, but your anemia is developing, that the hemoglobin is dropping. That's the importance of the RBC count. Then mean corpuscular volume. In short, what it means is what is the average size of the red blood cell. This becomes a very important parameter. Like the moment you see the CBC and patient has a low hemoglobin, the next question should be what is the MCV. Normally it's 80 to 100. If it is low, that is below 70, then it's microcytic. It could be iron deficiency anemia. It could be anemia of chronic disorder. If it is high, that is above 100 or 105, then it becomes macrocytic. It could be megaloblastic. When it is between 80 to 100, it will be normocytic, so that it is not giving us. Another is the mean corpuscular hemoglobin, that is the amount of hemoglobin content. If it is below 26, again it means hypochromasia. So microcytic hypochromic, that is the classical of iron deficiency anemia. So in iron deficiency anemia, you would expect MCV, MCH and MCHC also go low. Mean corpuscular hemoglobin concentration. This has an importance because MCHC will be increased when there is a rigid RBCs or larger RBCs, like in cases of spirocytes, which is again if you have a patient who have a suspicion of hereditary spirocytosis or has an autoimmune hemolytic anemia, the first hint could come from the MCHC, which MCHC could be higher. Red cell distribution web is a variability in the size of the RBC. In a simple term, what it means is what is the variation in the size, and that reflects the anisocytosis. On a peripheral smear, when we see the manually peripheral smear, anisocytosis is there. So these are the indices which gives us idea. So whenever there is an anemia, as I discussed earlier, low MCV with high RDW. High RDW because the RBCs are on a different phase of development because of lack of iron, and that's why there is a lot of anisocytosis. So is true for vitamin B12 deficiency. So low MCV, iron deficiency, high MCV with RDW increase, vitamin B12 folic acid. Of course, there are a lot of other combinations, but these are classical. So like if you have a low or high MCV along with RDW, becomes classical iron deficiency or B12. The rest of the conditions have a lot of overlap, so with experience you will be able to differentiate them. Coming to the peripheral smear, which is, as I said, very important, there are certain the terms which are used. When you are coming across a CBC report and the pathologist has signed out or the hematologist has signed out the reports, so anisocytosis means a lot of variation, which is again indirect way of expressing RDW. Hypochromic microcytosis, this is seen in iron deficiency anemia. Macrocytosis can be megaloblastic anemia, or it can be there in myelodysplastic syndrome or aplastic anemia. Microcytosis, again low MCV, which is iron deficiency, and poikilocytosis, that is variation in the shape of the RBCs. So if you have a very severe iron deficiency anemia, then you will have a marked anisocytosis, poikilocytosis, target cells, pencil cells. These are all descriptions which you will get it on peripheral smear examination. Reticulocyte count basically gives an idea of how good or functional is the bone marrow. It's 0.5 to 2.5 or 2%, and generally it is corrected for the hemoglobin and then the expression. So basically what it says that how good is your marrow to respond. So if you have a condition like anemia or pancytopenia with MCV low, that means your marrow is not functioning good. Your MCV is high, then it means the marrow is functioning well, and the cause could be the blood loss or hemolysis as a cause. So reticulocyte count helps to differentiate the marrow capacity or marrow response to that sense. Coming to the neutrophil, the normal neutrophil count is around 4,000 to 10,000 or 11,000 in certain population. They can be increased in infection, inflammatory disorders, medications. Hematological cancers and myeloproliferative disorders can also increase your WBC count. There is a group of disorder called myeloproliferative neoplasm where it can be as a cancerous increase, and treatment is always attend to the what is the basic cause of that. So let us see in a differential count, if the neutrophil is increased, generally it is bacterial infection, inflammatory disorder. So if somebody has a rheumatoid arthritis which is very active, and then you find the WBC count is 14,000 with neutrophil leukocytosis, then it is attributable to the rheumatoid arthritis. A lot of connective tissue disorders will lead to reactive leukocytosis. Then stress or certain drugs, especially prednisolone. The moment patient is put on prednisolone for some reason, the WBC tends to go up between 10 to 20,000 and neutrophilic leukocytosis. Many of you call me back saying that your ITP patient you started on for platelet increasing, the WBC is now increasing, and then you are worried saying that whether there is a leukemia developing in this patient. So now the prednisolone is one of very common drugs where the WBC can increase, and of course wherever WBC increase is there, they are always worried about leukemia. It all depends upon the differential. So we are talking about neutrophil. If it is neutropenia, the neutrophils are the primary cells which tackles the bacterial infection up front. So if you have a neutropenia, you are always exposed to the infection, and that's why it is very important. Whenever somebody has low count, it is important to pay attention to what is the neutrophil percentage. Your count could be 2,000, and if your neutrophil percentage is only 10%, your absolute neutrophil count becomes only 200. Then you are severely neutropenic. At the same time, you have a 2,000 WBC count, but you have 80% of neutrophil, it becomes 1,600. So in that case, the risk of acquiring different infection is very different, and that's where we would use either growth factor, or if the patient has a fever, how aggressively that fever to be tackled depends upon this absolute neutrophil count. Most commonly, now you see many of your patients taking chemotherapies, and the same principles will apply when we are looking at the neutrophil. Uncommon causes of neutropenia could be autoimmune cause along with systemic lupus erythematosus, immune deficiencies, states and all that we will not go into. Lymphocytosis classically occurs with a viral infection, inflammatory bowel disorders or CLS, and other causes of lymphopenia. The causes of lymphopenia could be connective tissue disorders, aplastic anemia. So aplastic anemia, where your count is low, you typically have the differential getting grossly abnormal. Your neutrophil percentage tends to drop and the relative lymphocytosis tends to happen in cases of aplastic anemia. Monocytosis generally seen in recovery phase of infections or chronic infections like tuberculosis and can be in the part of the myeloproliferative disorder, not significant when it is decreased. So the eosinophils are increased when there is allergic disorders or parasitic infection, or they can be hypereosinophilic syndrome. So anybody who has a eosinophil count more than 1500 has a significance, because the more the eosinophil circulation into this body, they can be damaging. They can create an end organ damage, and that's why it is important to work up this patient for eosinophilia and sort out and treat them, because eosinophil otherwise end up damaging the heart, liver or pancreas and so on. Basophils again can go up in certain leukemias and myeloid metaphasia, so on. Again, the classical is chronic myeloid leukemia, where it will be. There are different technologies which are used in these counters that we will just go through. 3-part differential system. So there are different machines available. 3-part, when they are giving 3 differential, that is lymphocyte, granulocytes and mix. These are the machines which are there in routine labs, and this is how the histogram, that is the MCV. You can see what is the average MCV. It is looking like around 70-80 here, and the RBC, the neutrophil, the leukocyte graph shows that there are granulocytes and there are more lymphocytes. So this is where the 5-part counter looks. Then the 3-part counter looks, and then 5-part has a more differential, that is they can give 5 differentials. So in high-end laboratories with the hematology work, we need 5-part, and then they will give you a graph where we can make out which type of cells are increased. So before even I see the peripheral smear, from the graph itself we can make out, depending on the size and granularity, that which type of cells are increased. This is again different machine which is showing the same thing, and this is how the slip of 5-part looks like. And 7-part differential. Now more and more sophisticated machines are coming in institutions. We are using multi-parameter width. So they give more reticulocyte count, or they almost literally seize the cell. So like flow cytometry, we have almost evaluation or machine-based very accurate evaluation of these cells are done. And this kind of machines, they have a phenomena called flagging. So something is abnormal, they will give signs like this. That means that the operator or the pathologist or hematologist has to look into that specific. Say like if WBC is going up and they can't differentiate what is the differential, then the machine will flag, and the responsibility then is on the doctor to sort it out. This is called flagging. I'm so sorry. So let us come to few RBCs. So with the counter slips to see whether we can interpret some of these CBCs on this background knowledge of how to interpret the CBC. So this is one patient. We are not discussing the complete case here, that we do it in our case discussions. So hemoglobin is 8.5, WBC is 9000, and then you have a platelet of 188. So what is wrong here? So first, once the anemia is there, my first attention goes to MCV. MCV is 69. Is it low?
No.
Yes. So then I look at, that means this is a microcytic. Then I see mean corpuscular hemoglobin, that is 20. The lower range is 26, lower cutoff. So this is also low. So what this means is microcytic hypochromic anemia. So before even we see the smear, then we pay attention, the differential looks fine, rest of the things fine. So what at RBC count is proportionately decreasing. So what is the interference? Interference out of iron deficiency. That's very good that at the end of this, at least iron deficiency anemia and megaloblastic anemia, these are the very straightforward. I don't say that every CBC could be that straightforward, but this is one of the most common type of anemia you come across in your clinical practice. And then the next investigation to be asked is iron studies, and then you investigate the patient for iron deficiency anemia. So next case is again hemoglobin is low, WBC is slightly low, 3.5.